Hi, everyone. If you can all take your seats, we're going to continue with our Research Day program. And we're now moving into grand rounds, which is part of our normal grand rounds process. But today, grand rounds is part of Research Day. And I'm very pleased to introduce our speaker for grand rounds, Dr. Erick Forno, who comes to us from Indiana University, Riley Children's Hospital. Dr. Forno is a pediatric pulmonologist and vice chair for clinical research in the Department of Pediatrics at Indiana University. He serves as chair of the program committee for the American Thoracic Society, which I just learned is holding its conference, its annual conference this coming weekend and next week here in San Francisco. He's also vice chair of the Society's Scientific Advisory Committee and is helping to establish a severe pediatric asthma consortium in the United States. Dr. Forno runs an NIH and NSF funded research program that focuses on the epidemiology and genomics of asthma, the effects of obesity on childhood respiratory health, and the use of technology to improve respiratory health for children. And today, Dr. Forno will present his work on how predictive analytics and collaborative bioengineering research can improve patient care in pulmonary medicine. So please welcome Dr. Forno.
Thank you. Hi, everybody. Can you hear me okay? Excellent. So first of all, thank you for the invitation, for the opportunity, for the kind introduction, and thank you everybody for being here right during lunchtime. As Dr. Hirsch mentioned, one of the things that I'm focused on, beyond just the focus on disease specifics of asthma, of childhood asthma, is how we can leverage collaborative research to improve outcomes and the lives of our patients. And so today, I'm going to talk about predictive analytics and also bioengineering collaborative research. In this specific particular talk about, well, I'll focus on pediatric pulmonary medicine, but I think a lot of the principles that I want to highlight would apply to other fields and other complex diseases. I have no conflicts of interest other than grants that we've used for different aspects of our research. And so I'll talk about three things, and you'll see the first two are a little bit more interrelated. The bulk of it will be what you see in red is how we use genomics as potential biomarkers or different aspects of clinical prediction. And at the end, I'll talk about one project that's completely different than all the others, but I think it's really exciting, and it's also an example of how collaborating with people who view the world differently can lead to really exciting science and really exciting projects that hopefully will benefit our patients. So I don't want to belabor this too much. I think anybody who deals with patients with asthma knows that the prevalence has increased substantially since the 1970s or 80s, where the prevalence was about 2 to 3%, to about 8 or 8.5 or 10%, depending on how you measure it. And it has probably remained stable over the last 10 or 15 years. The reason why I show this is, one, because it's an important problem, but also, let me see the pointer. Also because you can see the prevalence goes from about 2 or 3% to about 9%. And there is no way that that is produced only by the genetic predisposition of asthma, right? There isn't a way that we accumulated enough new SNP mutations to triple the prevalence of a disease. At the same time, the environment hasn't changed that much. And so probably there's a little bit of truth in both, where there was some genetic predisposition that is now uncovered by changes in our environment and the risk factors and exposures that people encounter that leads to a much higher prevalence of asthma than just 30 or 40 years ago. You may have seen this as well. This is the Asthma Predictive Index. And the reason why I show it is because I always tell people asthma is one of the most common chronic diseases in childhood. It affects about 1 in 10 or 1 in 12 kids. And we still don't have a good way to diagnose it other than asking a lot of questions and accumulating clinical evidence. And so this Asthma Predictive Index was published about 25 years ago. And if you look at it, it's associated with a higher risk of higher or lower risk of asthma, depending on whether you have a positive or negative score. But what I show, the reason why I show this is if you look at it, is these are questions that we should be asking our patients anyways, right? Does somebody in your family have asthma? Did you have eczema? Do you have symptoms outside of colds, et cetera, et cetera? And really what it shows is that we only accumulate evidence to say, well, high probability that you have asthma, and therefore I'm going to call you or I'm going to diagnose you with asthma or not. And I think we should be able to do better for a disease that affects so many children. The problem is, no matter how you look at it, asthma is complicated, it's complex, it's multifactorial. So whether you're an immunologist or an allergist or a pulmonologist and are interested in atopic versus non-atopic disease, if you're an investigator or a person who's interested in disparities, there are community level versus individual level risk factors that can worsen asthma outcomes and lead to disparities, but it is complex. And while that may be exciting for me as a researcher, it means it's very complicated and not as exciting for my patients when I'm trying to help them be better or do better in terms of their asthma control. What I think we all agree is that asthma has a significant genetic component. Depending on how you measure, people have estimated the heritability of asthma at about 50%. So estimates range from the 30s to about 90%, depending on whether you do twin studies or sibling studies or epidemiological studies. But that's a really high component of heritability for a chronic disease. It also means, though, that the other 50% is not hereditary. And so it's probably related to factors that intersect or interact with your genetic predisposition. If you look at the GWAS catalog, right, the catalog where you deposit all the results from the genome-wide association studies, there's at least 200 publications related to the genomics of asthma. 500 SNPs have been, I stopped searching last year because it really doesn't make sense for me to update this slide, because the point is there have been a lot of studies of the GWAS of asthma. In the last 4 or 5 years, about 50 per year, looking at SNPs of asthma. And unfortunately, we haven't been able to find 1 or 2 genes that explain a high proportion. And I think part of it is because we got excited and carried away when we were able to interrogate the genome to look at SNPs and thought, well, we're going to have the answer for chronic disease or complex disease like asthma. And we decided at that point, at least, to skip everything that comes in the middle. And it's important because the genetic code shouldn't be changing, right? For the most part, I think we can say that our genetic code in general is immutable, unchanged. And so it's difficult to pretend that because of SNPs that you were born with, I can explain the whole natural history of a complex disorder across your whole life, regardless of your environmental exposure. And so over the last 15 years, 10, 15 years, people have started to focus a lot more into how all of these intermediate steps build on top of your genetic predisposition to lead to these chronic disorders. There are multiple ways where all of our cells that share the same genome, the same genetic code, end up being an alveolar cell or a neuron or a hepatocyte, right? And so there are areas of the genome that are silenced or expressed depending on what kind of cell, what kind of tissue. They also turn on or off depending on what kind of exposure. So if you're inhaling air pollution, there are genes that are going to get activated or deactivated in response to that, even within the same cells. And so I'll talk a little bit today about DNA methylation. It's one of those mechanisms that leads to either higher or lower gene expression, depending on the levels of methylation. And so this is going to be a gross oversimplification. So if everybody does molecular biology and gene regulation, please forgive me. But in general, one of the ways methylation works is that if you have more methylation, chromatin gets very compact and difficult to access, and therefore that suppresses gene expression. Whereas if there is little methylation, then the chromatin is a lot more open for translation, and therefore that promotes gene expression. And so that's just one of the mechanisms through which we can alter which proteins are or which genes are expressed in our genetic code. And so studying the genomics has several advantages. Most importantly, it helps us understand the pathways and the mechanisms that underpin a lot of our chronic disease and chronic disorders that we see. So it furthers our understanding of disease pathogenesis and pathobiology. But what I want to focus on today is really how it serves as potential biomarkers that we can hopefully one day incorporate into the clinic for the benefit of the populations we serve. So why is it important? Why is it interesting? Why is it beneficial? Again, like I mentioned, there have been studies that have shown, particularly for asthma, for many, many years, we were looking at blood. And it makes sense if we think asthma has an inflammatory, immune-mediated component. But then people started to have the ability to look at airway respiratory epithelium. And what you find is that there is significant differences, whether you're looking at blood here in red, nasal or oral epithelium, and then here bronchial and nasal epithelium. And so if you look at the similarities or the distances between the expression of those genes or the methylation of those genes, they're clearly growing apart, right? So the further relationship between the tissues, the more different they are. And what does it mean, though, that over the course of many decades, when we were looking only at blood, we were only focusing on this corner of the pathobiology of asthma. Now we have the ability to look at, doesn't mean we shouldn't look at blood. It's crucially important. But I mean, there was a whole proportion of the disease pathogenesis that we were missing if we were not looking in the appropriate organs. Now, one of the things that always has driven the way I try to think of research as a clinician is how is that going to eventually benefit my patients? It could be that it's a direct benefit. It could be that it's 10 steps or 10 years removed. But I always like to keep that in mind and say, okay, down the road, how is this going to help my patients? And so I'll give a few examples and I'll run through them a little bit quickly, just so that we have some time for questions at the end. I'll try to explain what each of those results and each of those graphs mean, but I want you to please try to focus on the message that I'm trying to come to you today with, rather than specifically the details. I'll be very happy to talk about the details if anybody has questions, but I just want to make some points here. And so one of the areas where I started to try to understand whether transcriptomics or genomics in general can help us improve precision medicine is whether, for example, can it help in the diagnosis of asthma? As I mentioned, what we do is we ask a whole bunch of questions about, do you cough, do you wheeze, what makes it better, what makes it worse? If you take albuterol, does it make better? Anybody else in your family have the same problem? And so there are inevitably some times where it's difficult to diagnose, or it would be helpful to have objective biomarkers to help with the diagnosis. And so in that regard and with that goal, one of the things that Dr. Ivana Yang looked at in the University of Colorado several years ago was, could the nasal epithelium serve as a proxy for what happens in the lower airways? And she found some differences, but overall, the conclusion was that there is enough of a correlation that it can show or it can serve as a proxy of what's happening in the lower airways. The reason why it's important, right? I can have somebody come to clinic and swab their nose. Much easier to do that than say, well, I'm going to do a bronchoscopy on you to see what's happening with your airways. Not only that, but they found that there were a lot more signals in the nasal epithelium, probably because it's exposed to the environment a lot more. And so a few years ago, when I was at the University of Pittsburgh, working with cohorts that Dr. Juan Celedon, who was my mentor and my division chief, he collected cohorts of kids with and without asthma, in this particular case from Puerto Rico. And what we decided to look was at the kids who have atopic asthma versus the participants who were healthy controls with no asthma and no atopy. And here's the definition of atopic asthma. And what we did is we obtained nasal respiratory epithelium samples and measured DNA methylation and gene expression in those samples. And we just compared the cases versus the controls. And you can see the summary of the results. There were 7,000 CpGs or methylation markers and 6,000 genes that were differential between asthma and no asthma. And you can see here, like I mentioned, these two corners where there is here in the x-axis methylation and the y-axis expression. So here, these genes had higher methylation and lower gene expression, and vice versa, lower methylation and higher gene expression. And so this was exciting. It certainly made for a good publication when we're able to publish 7,000 markers that are significant. But what do we do? What do I do with that, right? So on one hand, collaborations with our basic science colleagues is going to be hard if I try to tell them here are 6,000 targets. On the other hand, also not much I can do in terms of clinical studies. And so using a lot of complex biostatistics and bioinformatics approaches, we reduced those 7,000 markers to just the 30 that yielded the most information about whether you're a case or a control. And what we found was that we had about 90%, 88% accuracy to differentiate who had asthma and who didn't have asthma. If you've seen this curve before, here's the specificity and the sensitivity. And the closer you get to this corner, the closer to perfect in terms of differentiating the two groups. And what you can see here is, again, right, the accuracy was about 88%. More importantly, this, as I mentioned, was a cohort of Puerto Rican children. We replicated in a cohort of African-American children from the US and a birth cohort from Europe. So two very different populations from different ancestries and different environments. And what we found was similarly about 85% accuracy. And so again, the idea would be that it's impossible for us to pretend that we're going to use 6,000 markers in clinic. But I could foresee how somebody could create a chip with just 30 markers, where one day, if you're a primary care provider and you're not sure if this kid has asthma or not, you swab their nose, you send it to the lab, 2 or 3 days later, you get the results, and that can help you orient. It's never going to take away your clinical index of suspicion, but it can help you with those difficult cases. And so this is, I think, one promising area in aiding with disease diagnosis. So that was methylation. So then we looked at gene expression, so transcriptomics, exactly the same analysis in the same group of people in the kids who had either asthma versus controls in the Puerto Rico cohort. And we replicated using 3 data sets. 2 of those data sets were also in children, and 1 data set was in adults. And then you could see the different races and ethnicities here. Some are non-Hispanic white, African-American, and then our cohort, of course, were Hispanic and Latinos. And we found very interesting results. We were able to replicate similar findings to the methylation, but we also found these gene nodes, if you will, where if we look at the gene expression, genes don't express in isolation of everything else that's happening. So if you put everything together and see how genes vary together with other genes, you can see how they potentially may be affecting, or at least they may be changing together. And we found these gene nodes that you see here in yellow that didn't exist in the controls. There were no such correlations in the controls. And so presumably, again, one day I could say, well, maybe these genes are important. You see here, for example, periostin is a marker of atopy and a marker of atopic inflammation in asthma. So somebody could say, well, maybe we should look at those more important genes instead of being lost in the hundreds and thousands of markers. And we were able to get, again, about 90% accuracy to identify asthma versus controls. And we did 3 types of approaches. 1, using the genes with the best p-values. 2, picking the genes with the greatest difference between cases and controls. Or 3, using these 17 hub genes. And so instead of doing 6,000 or 30, we were down to 17. And we still got about 85, 90% accuracy. And so again, the idea that maybe this is something that one day could be helpful in clinic. There have been other studies that have shown, what I think is exciting from this study, where they looked at kids with asthma, dermatitis, eczema, and allergic rhinitis, is you can see these genes that are here in the middle that were associated with all 3 atopic comorbidities, is that the expression goes higher depending on whether you have just 1, 2, or all 3 atopic diseases. And so this serves as a proof of concept for us interested in clinic, that it may not just be able to tell me yes asthma or no asthma, but if the doses are higher, then, or maybe there's a dose-dependent response where the higher the dose of those genes, you can find in kids who have more atopic diseases in one single individual patient. And so again, those response is an interesting proof of concept for the future. Beyond asthma diagnosis, we all know that one of the most difficult things in asthma is predicting asthma exacerbations. They cause the majority of morbidity, particularly acute exacerbations in terms of emergency room visits, hospitalizations. Thankfully, we don't have that many deaths from asthma, but clearly the majority of those happen during acute exacerbations. And yet we don't have a really good way to predict it, right? If you think of your asthma action plan, where you're teaching your patients is, all right, you need to take this medicine to try to prevent it. And this is how you recognize when it starts to happen. And when it starts to happen, you're supposed to react by giving medicines. We don't really have a good way to predict who's going to have them. And so what we wanted to look and see if genomics can help us, if transcriptomics, looking at gene expression, could help us. And so this is data from a small study based on the clinical trial of vitamin D for asthma. Within that subgroup, within that group, we had 66 kids who had same nasal brushings, and they were 6 to 16 years of age. We followed them for a year, and I wanted to see if baseline gene expression at the beginning of that year would predict how long it was going to take for them to end up in the emergency room or in the hospital. So we used these 66 kids in that age range, and we looked at transcriptomics, again, gene expression from the nose, adjusted for multiple things. And then we looked at the top genes. In this case, it ended up being 9 genes to create what we call a transcriptomic risk score, a TRS. So if your score is higher, does that mean you're at higher risk of having an exacerbation soon or not? And so these are the summary of the results. So in blue, what you have are the kids in low risk. And you can see here, about 20% of them had an exacerbation over a course of a year, compared to about 75% of the kids the children in the high risk group. And you can clearly see the trajectories are different. After we adjust for age and their baseline severity and their medications and all those other things, the children in the red group had a rate that was 5 times higher in terms of how frequently they ended up in the emergency room, or the number of days until their first exacerbation that landed them in the hospital. More interestingly, though, I mean, I think that's already really interesting if you could differentiate who's going to have an exacerbation the next year or not. But if we focus, I usually see my patients with more significant asthma every 3 months. And what we looked at here is you can see this mark of 82 days. At about 82 days, or about 90 days, 0% of this low-risk cohort had an exacerbation, compared to about 25% of the children in the high-risk cohort. So again, going back to the clinic, right? If you're in clinic and you have one of those patients where you're like, I wonder if I could safely decrease the fluticasone in this patient, maybe you could do the swap. And if they come in this low-risk group, then that gives you an extra tool to say, well, maybe it's safe to stop that inhaled corticosteroid. Or the other way, right? If you have that patient where you're not sure, should I just keep them on that? Should I increase their treatment? If they end up in the high risk cohort and they have a 1 in 4 chance of ending up in the emergency room before you see them in clinic again, maybe I should do something different for that patient, whether it's increasing medication or some other intervention, asking parents to stop smoking or whatever else is that we could do in our clinical management. But I think it highlights, and again, right, this is a small study. It's a proof of concept, but it highlights what hopefully one day would be just like we send them to do exhaled nitric oxide, or we send them to do spirometry to try to see what we're going to do with them. This could be potentially a biomarker that we can use in clinic. So before I was at the University of Pittsburgh before moving to Indiana, and we started a cohort that is now almost completely recruited. We're going to try to validate those findings. We're also starting the cohort at Riley to validate as a third independent cohort to see if this really holds up, right? Studying one time doesn't necessarily mean it's going to hold up when you try to replicate it. So we're going to be working on that with a larger group. Going to be 120 kids in Pittsburgh, and hopefully eventually we'll get to 200 children at Riley. One other aspect that is important, particularly for a complex disease like asthma, is trying to understand which endotype of the disease, right? For many years, we thought of asthma as just being one thing. But just because somebody has narrowing of the airways because of inflammation and they cough and wheeze, doesn't mean they have the same endotype. They may have different types of inflammation. They may have different routes where they got to that point. And we really don't have excellent biomarkers to classify. And so we were thinking, well, could this help us understand? And this is work that was done by Dr. Cristina Gallero and Molly Nue, who's a PhD student at Pittsburgh. I participated in the study before I left. The cohort is led again by Juan Celedon, who's the division chief there. And what they did is, again, using the same type of nasal swab to look at gene expression, they looked at just 8 genes that had been published in the literature to see if you have type 2 asthma, Th17 asthma, or the gene expression for those markers are all low. So what you see here, there's a lot of figures, but what you see here is these are the genes that are related to type 2. These are the genes related to Th17 inflammation. And what you can see here is there's a group that has high expression of type 2. So this is type 2 high inflammation. these are the type 17 high inflammation, and these are the ones that are low for both. So for simplicity, I'll call it type 2, type 17, and low inflammation. And when you can see here in this first cohort was one of the Puerto Rican cohorts, you can see there's a nice separation of the participants in that group. You can see clearly this group is very different than this and is very different than this. The next thing you can see is that when they took it to 2 other cohorts, you see the same findings. These are completely independent cohorts. This is in Puerto Rico, this is in Puerto Rico, and this is in Pittsburgh and other centers. And even though the numbers of patients change, you can see the same phenomenon. So what it tells me is just using 8 genes, I can see if they're type 2, Th17, or none of the above. And I can replicate it in different cohorts. They also looked at various multiple ways to look at how to differentiate the 3 groups. And the reason why I showed this right here in the columns, you have all the three cohorts. And then here you have multiple statistical ways to approach the clustering. And what you can see, the reason why I show it is because no matter how you approach it, there's very robust clustering, right? You see the red, the green, and the blue very well separated, no matter which method you use. And so it wasn't that we just got lucky or we selected the best result. It really is very robust to the type of analyses. And more importantly, what then they did was they looked at the 2 biomarkers that we use more frequently in asthma clinic, IgE and eosinophils, together with exhaled nitric oxide, which we don't use as often, but it's also one of the markers that we use. The reason why this is important, if you start to look at the kids who have more severe asthma, and you start to think on whether they need biologics or not, these are the 3 biomarkers that we have to decide if you're eligible for a biologic and which one. And so what they found is that using these 8 genes and these clusters, they could sort of replicate what we use, is whether your IgE is high, your eosinophils are high, or your exhaled nitric oxide is high. You could assign them to those clusters. Why is it important, right? Of course, I'm not going to propose that we do transcriptomics and nasal epithelium instead of measuring a CBC. But what it shows is that we were able to replicate what we've accumulated as clinical knowledge and clinical evidence from multiple clinical trials just using 8 genes. And so imagine if we start to then delve in all the other 16 or 20,000 genes that we haven't quite looked at yet, we could be able to eventually find other biomarkers or other targets that could be used for different types of asthma. So if we have a patient in clinic that's not responding to an inhaled corticosteroid, should I go to an inhaled corticosteroid with LABA? Should I go to a biologic? Should I start tiotropium? And so instead of just adding things on to see what works, maybe one day we have a way to endotype patients to see what medications are more likely to help. Another thing then is, well, okay, I start treatment, and what do we do with our patients with asthma? We tell them, well, come back in 3 months and we'll see if it worked. I think we could hopefully do better than that. And so I think one day what we would like to know is all of the 10 potential steps that you could take along the way, what are the 2 or 3 that are more likely to help a patient versus the 5 or 6 that may be not so helpful potentially for that patient? We may still need, nothing's going to be perfect, right? So we may still need to do some trial and error, but at least it's a little bit more directed rather than just one approach fits everybody. And so for this, because asthma is too complicated and it would take too much of a large cohort to try to answer that question, one of the things we focused on was on cystic fibrosis. And so, as you all probably are familiar with, in cystic fibrosis, these modulator drugs, the pharmaceutical approach or pharmacological approaches with modulators have been life-changing in our patients with CF. They've made a huge impact in their quality of life, in their survival. It's nothing short of a miracle in terms of what benefit patients are deriving. However, not everybody really responds similarly. And so I usually show these. These are the 2 clinical trials published in 2019 in the New England Journal and Lancet, where they looked at the triple modulator therapy or Trikafta versus placebo in gray. And you can clearly see there's a group difference, right? This led to FDA approval. So there's a very clear difference between the 2 groups. But that's just the groups, right? There are the individual patients here, for example, where this patient who received the drug lost 10% of their FEV1. And so for that patient, for whatever reason, that drug is not necessarily working as maybe for this kid or for this adult who gained 30% of them. And so there is that small group in the bell curve that maybe are not benefiting from the medication, and we don't know why. It could be that they're not taking it appropriately. It could very well be. But it could also be that the pharmaceutical approach or the pharmacological approach is not the optimal for them. So what if we could use transcriptomics as a biomarker to try to identify who's going to benefit from a certain intervention? And so this is data that we collected when I was in Pittsburgh. And what we did is in adults and then children who were going to start Trikafta, we got baseline nasal swabs before they started the drug. And we wanted to see if that would predict response. And also we got or after 3 to 6 months, we got another set of transcriptomics to see which genes had changed. And what you can see here is before versus after. On average, the cohort improved their FEV1 by about 8%, but that also means that about 60% of them were non-responders. So we define those as patients whose FEV1 did not improve at least 5%. So if your FEV1 improved 5% or more, you were a responder. If it didn't, then you were a non-responder. And there's a couple of things that I want to highlight. First thing is the changes before and after. So you see multiple genes in nasal epithelium that are the change before versus after starting Trikafta. But what I think is even more interesting is the genes at baseline that predict whether you're going to respond or not. So these are the genes that predict response in FEV1. These are the genes after we follow the patients for a year. These are the genes that predict whose FEV1 over the whole year is going to be better compared to the year before starting the drug. And then when you put this into a computer model and try to select this transcriptomic risk score, we have about 88% accuracy to identify who is going to improve when we start the medication. If I add all the other variables, like which medications they were on before, their genotype, et cetera, that goes to about 97%. So that means in this cohort of 31 or 35, I was able to classify accurately responders versus not responders with the exception of one. And so again, right, I'm not proposing that we should take away the medication from these patients, but, and by the way, this was also about 92% accuracy or 88% accuracy for who was going to gain weight after starting the medication. So again, it's not that I'm going to propose that in kids or patients in whom this could be life-changing, that I'm going to deny them the medication. But if I have a patient on modulator A that is doing well, and then I have a proof or a test that can show me that it's maybe not worth changing to medication B because they're already doing well on this one, that could help. And then the other thing that I think would be more important is it could help us select patients for future clinical trials, right? I don't want to include those that are going to be doing great with other medications. I want to include those that are likely not going to benefit from the medications we have. And so again, another proof of concept of a small study that needs to be replicated that may show us that eventually this could help us decide which medications are more appropriate based on whether the patient is going to respond or not. Two more things. One is obesity and asthma. This is completely changed, I know, from what we've been talking, but I've been one of the other areas that I am interested in is in how obesity worsens your risk of developing asthma. And when you have asthma, having obesity also makes your asthma worse. You have more symptoms, it's more severity, more frequent exacerbations. Overall, they do more poorly. And it's a complex interaction, right? Both obesity and asthma are complex diseases. So if you put them both together, then it's either, I would say, hyper complex. And so one of the things we decided to do as we try to understand why that is, many studies have looked at blood and what inflammatory signatures you see in blood in kids who have obesity and asthma and are doing worse. And so what we decided to do is, well, maybe if we're saying obesity is to blame, we should look at adipose tissue under the hypothesis that in some patients, the adipose tissue is not just more abundant, but it has changed phenotype and is more inflammatory, and that eventually is also affecting the airways. And so we created a cohort where we've been collecting adipose tissue, subcutaneous and intra-abdominal, to look at transcriptomics in kids with asthma and without asthma. And this is a preliminary analysis when we had about 130 patients. When you can see is that, of course, as I hypothesized, patients with asthma tend to have higher proportion of obesity, higher percent body fat. These are things we've demonstrated in previous studies. You can also see some inflammatory changes. But what I want to show here is these are the genes in adipose tissue whose expression is associated with lung function. And so it's a lot to digest, but it's patients with and without asthma. In this case, looking only at the patients with asthma, we measured adipose tissue gene expression, and we wanted to see which genes were associated with a lung function. And this is in the group of patients with a healthy weight, about 100 patients with a healthy weight. And if you've never seen a volcano plot before, here you have the fold change on the x-axis. So higher expression means associated with higher lung function. And then here, it's inverse, right? So either higher expression of the gene, lower lung function, or vice versa. And then here on the y-axis, you have the p-value. So these red and blue markers here are the ones we're interested in because they are either associated with better lung function or with lower lung function. And this is again in the patients of a healthy weight. And then this is what you find in patients with obesity. So even if you're not a bioinformatician, you can tell that there's a difference between the two groups, right? There are some genes, I don't know if it's causal, right? But I know that there's an association between adipose tissue expression and FEV1. But look at what happens in the patients with obesity. And so clearly, very different scenario. Something in adipose tissue is very different in the way that it associates with lung function. What we're going to work on next is to try to see how we interrogate to see which ones just happen to be associated, which ones are a cause that leads to changes in lung function, or which ones are a consequence, right? So if your lung function is better, it may also affect gene expression in other parts of your body. So we're going to work on that. We've also started to do single nucleus work on this to try to see not only which genes, but which cells are producing the genes, whether it's the adipocytes, but also all the inflammatory and immune cells like macrophages and T cells that you see in adipose tissue. And maybe the adipocytes are not playing a role here. It's more the immune infiltration in the adipose tissue. We're also doing then translation to look and see with the products of those genes, how do they affect bronchial epithelium? So that's still all in the works, and hopefully we'll get some results in the next few years. So the last thing I would say in the next 5 or 8 minutes that I want to talk is completely different. And like I said, the reason why I show it is because I think it's also going to contribute for the precision medicine for our patients. But it's a completely different story that came from a meeting similar to this, where there were a lot of people. I eventually met a bioengineer who was interested in doing some work on biosensing. I had some interest in using bioinformatics and technology for asthma. And so this led to this project, and I'll show you. So there are multiple things that have changed. I think you're all very well aware of how things have changed in terms of technology. We used to have, for research in particular, limited data. They had to come in, they sat and they did 2 hours of questionnaires, and then they went away. And that was the end of the questionnaire, or we had to do it every time. Now we have access to large data that can be continuously collected and analyzed. And so I think there are a lot of things that are ripe for us to be able to learn how to use them for our patients. And so this study, one of the things that I was interested in was using smartphones as a technology hub for our patients with asthma. And so I thought, for one, that we could be able to collect continuous location information, or it could detect when a patient was sitting in the emergency room and it would ask, "Are you there for your asthma?" Yes. And then so the 3 days later, it could ask, "Did you end up getting admitted? Did you get prednisone? Are you feeling better?" And then as I started to talk to these group of bioengineers in Pittsburgh, they were interested in biosensing. So we decided to work on this project where we were using the smartphone speakers and the microphone to do basically Doppler echo pulses to detect chest wall motion. And what we used was this first prototype where you can see it would sit in the table, or you could hold it in your hand, and it would just detect your chest wall moving in and out, forward and backward. And with that, we were able, and a lot of calculations that are beyond my comprehension of signal processing, but that's what you have collaborators for. We were able to estimate FEV1, FEC, and FEV1, FEC, the spirometry parameters that we use to evaluate lung function. And you can see here FEV1 and FEC in particular was within 10% error. So not perfect, but good enough that you could say, well, maybe you could use this at home to try to get a sense of whether your lung function is getting worse. This was after the pandemic. So imagine if we had had this in the pandemic and we could tell parents to just monitor lung function at home and just give us a call if it changed. And so I think we thought this had potential. But then I said, well, why limit the Doppler analysis to the outside of your chest wall? Why not create an adapter and focus the sound waves and actually get into the airways and see if we can map the inside of the airways instead of just the chest wall motion? And so this is what we did. Initially, they worked in the lab and they used different size or calibers of tubes where you can see it goes either down or up and down or V-shaped tube. And you can see what we were getting with the phone matched the shape of the tubes that we were using. And we could accurately measure the distance as well. And so the idea of AWARE was to use acoustic waveform to evaluate the airways. And so if you isolate the airways, it really is a series of tubes. And could we map that using the acoustic waveforms that we're sending? We already have something similar with oscillometry using pressure, but what that measures is the resistance and the compliance of the system. It doesn't really localize as much. And so we thought maybe this was an interesting concept. And so if you oversimplify and turn this into a geometrical map, what we expected was that there would be an area, a wider area in the mouth, then the pharynx, then the lower pharynx, then the vocal cords, and then all the lower airways. This is what we expected to find. And really, that's what we find. So we can map all the diameters of the airways of the things as you go through the distance. Moreover, if we do a 3D printed, what we can do is we can find a heat map of what that airway looks like. And if I pinch in two different sections, you can see here, right, there's a dent here from when I pinched that wasn't here. And then if I pinch in a different position, then the dent is here. And so we were able to map those pinches or those obstructions within about 1 centimeter accuracy. And then we were able to recreate the total area, cumulative surface area of the airways as you got out of the, or more distally from the focus of the sound waves. And so this led to multiple projects. Eventually, we started an R1 last year where we're recruiting about 800 subjects. We're going to have pediatric and adult controls, asthma, CF, COPD, airway malacia, and other things. And we're going to try to see, one, can we estimate lung function? Two, can we classify the various different diseases, right? Is it good enough to say you have asthma, no asthma, you have CF, not COPD? And three, can it help us understand if there are early changes that predict who's going to get in trouble in the next few days or few weeks? So we've worked on chest wall motion, sonar mapping. There's also, we're recording audible spectrum because I think we can add that to see if we can improve accuracy. And then there's other applications, right? We could look at upper airway, to look at obstructive sleep apnea. Does a kid have like really large adenoids? Can we do that with a cell phone instead of having to necessarily do a laryngoscopy as a screening mechanism? So I think there's a lot of applications. But again, this shows just when you get in the room with people who do different things and you start brainstorming ideas, some cool projects can come along, and hopefully that will eventually benefit our patients. So I hope over the last 40-something minutes, I've been able to show that, for instance, right, genomics is an important tool to understand disease, to interrogate biology and underlying mechanisms as a starting point for translational medicine on either direction, but also hopefully one day as a biomarker that we can use in clinic to help our patients do better. And then likewise, that doesn't have necessarily just be omics, right? There are other ways where you can leverage new technologies to do something that is interesting and novel, and most importantly, hopefully, if this works, one day will benefit our patients. This is all huge amounts of teamwork. Like I said, right, 95% of the things I do are not things I could do by myself. There's area of expertise, whether it's clinical knowledge of different diseases, adipose tissue knowledge. I work with the surgeons. I work with endocrinologists. There's a lot of areas of analytics that I could never do myself. there's certainly areas of bioengineering that I would have to have another lifetime to understand what people are thinking when they view the world through their eyes. And so it's all really highly collaborative work. So both, whether it's at Riley, where I am currently working with an excellent asthma clinical research group, people in different divisions like biostatistics and Department of Molecular Biology, but also all the collaborators over time. Most importantly, always our study team and our study participants, right? All the research coordinators that have to hunt down those patients for them to come in, who do the collection, who do the legwork on a day-to-day basis. I think a lot of times they're underappreciated, but they're crucial. And most importantly, right, if I have to convince a 6-year-old to come into clinic so I can scrape their nose multiple times along a course of a year, I think that's a hero level participation. So I always appreciate them. Thank you very much.
Dr. Forno, thank you. That was really fantastic. Usually, I just use my cell phone as a thing that I spill coffee on. So look, this concept is wildly advanced. Can you talk us through the study where you got the omental fat? And like, how was that obtained? And how did you even think of that?
So thank you for the question. The question is about how did we obtain the fat tissue. That's a trade secret. No, it really was a lot of very close relationship building with our surgeon colleagues who collect that for us. And so it's very careful selection of which patients who undergo surgery are eligible, under which circumstances, whether the surgery is not going to change the profile of what we're looking at. It took a lot of work. I was just going through some of that grant is up for renewal next year. And I was looking through some of the preliminary data that started in 2014. And so it took 5 years to get it to the point where it got funded. We're now finishing year 5 to 6. And so it took a lot of working relationship with colleagues to do something that I could never do. We were talking earlier with a couple of people also, for instance, in terms of collecting other types of samples like lower airway epithelium, lung tissue, lung biopsies. That's a lot of collaborative work. The reason why I got interested was really because even though the idea that somehow it gets from fat tissue to the lungs, it has to go through blood, we were still missing what we think, or we're blaming adipose tissue as the source of the whole problem, and nobody had ever looked at that. And people had started to look at adipose tissue for cardiovascular disease or others, and I thought, well, why not the airways? And I had the relationships to do it. So, thank you.
I was going to ask you 2 questions, but now you made me think of one other thing. How fat talks to the airway, extracellular message. But my questions were,
that was a comment.
That was a suggestion.
Yeah, no, I appreciate it. We have been collecting, we have additional adipose tissue, and we have blood in all these patients. So
there's fat, and then there's different fat. Do you have enough samples of diverse origin to discriminate the gene expression between different sources of your fat?
Yes, thank you. So we have subcutaneous and omental. And so we certainly have, now I wish I could send. I'm sorry?
Are they the same or different?
Oh, they're very different. Yeah, they're very different. I think we would have known, but I think it's going to be really interesting, particularly in terms of asthma. But I do think I also have already collaborations with people who work in endocrinology who are interested in these samples to validate some of the findings they have from mouse models or other experimental models. So it was really crucial for me, because if we had done just the subcutaneous fat, it would have simplified my life a lot, orders of magnitude. But I really wanted to get the intra-abdominal to compare.
And then I love the transcriptomics works and the different profiles of cluster. I think that's really compelling. The other thing you can do with genome-wide transcriptomic data is drug discovery.
Yes.
So you can tell the audience about CMAP and the other things I'm.
Yes, absolutely. So I think again, right, so one of the things I try to focus on here are things that are more directly applicable, hopefully one day, to our patients. But as you mentioned, I think there's incredible potential for target discovery, for drug development, or repurposing, right? And so nowadays, especially as science advances, it used to be that you had to know about the pathway and then had to put two and two together with a drug. We're having now more and more resources where somebody has already gone through thousands of compounds to look at what they target. Some of them have clinical applications, some of them have never been used. And so you can look at your genes and your pathways and compare to druggable targets, whether it's in a known database or, I hope eventually, one of the applications, I hate to say AI, but I think this is the right place, the place of discovery of things that we necessarily don't have eyes to detect patterns in our data. And so I think this is going to lead to potential opportunities then for translation to see if some new targets can be used for drugs. For obesity-related asthma, we don't have really good therapies other than tell them to please eat healthy and exercise, and that's harder to treat than asthma. So one day I hope that we can do that.
Well, the other incredible thing CNAC is they did it in dozens of cell lines at relevant dosages, mostly sub-micromole, but they made the same mistake GTEx did. They left the placenta. They left out the placenta.
Oh, this is something as pediatricians we're well positioned to push for and do. Yeah, I think there, and again, one of the things that I think is crucially important here is unlike when we were doing GWAS studies where your genetic code is going to be the same, so one sample, one and done. Here, the conditions under which you collect the samples, the exposures that the patient had leading to that point all matter. And so I think even as we think of which drugs serve for which cell types, it's also going to be important to try to put that into context of where does our patient come from that gets them to that point. So I think it's really exciting. It means a whole career in research. It also means it's going to be very complicated to sort of tease apart some of those signals.
Really amazing work in the bioengineering part was like, my question is actually about the first part of your talk on the methylation patterns and the transcriptional. Those data sets were from the same samples. Did I miss that?
The methylation and the RNA-seq, you mean? Yes.
And I was just curious about the relationship between the two data sets and if there's any mechanistic insights that you can get.
Yes. Yes, thank you. And that goes to my disclaimer and apology of like oversimplifying things. But yes, we have. So I haven't. People in Juan's group have continued to work on it. And as I mentioned, right, it's an oversimplification. There is a mechanism through which higher methylation reduces gene expression. But we have published more on whether that's short range relationship or long-term relationship. There are people who have studied, as you may know, right, there's also even chromatin loops that something very remote can actually approximate things in 3D space. And so what we see in the lab is not necessarily what you see easily in a cell or in an experimental setup, which is why it's important to do collaboration with basic scientists. But for this particular data, the inverse association tends to be more for the close relationship. So when the CPG and the gene are nearby, then that's an inverse relationship. The farther out you get, it tends to actually sometimes flip and be directly associated. And so what we think is that that's more related to activation of transcription factors that affect more remotely. And so I think it is certainly a lot more complicated than we thought at the beginning. I think part of the message there is that we need to be optimistic but suspicious, and also very humble in understanding that one mechanism is not going to explain everything. But yeah, we are looking at that. We also have nasal epithelium and blood. And so we're trying to study if the relationships are the same regardless of tissue, or if it's tissue dependent for those particular two. Thank you. Yes.
My question is about the iPhone measurements. So are the patients able to just, breathe normally, or is there extra respiratory effort required to have hyperswelling?
Yes, thank you. So part of the selling point was that it's not as complicated as spirometry. It's not tidal volume. So part of a lot of work that went into the piloting was how do we incentivize the airways to be as wide open as possible so that it would, because a lot of times when we are breathing, we think we're breathing through the mouth, but we're actually closing and breathing a little bit more through the nose. And so what we've settled in is a series of slow breaths, timed intervals that the phone will count down. And so you have to have some cooperation. It's usually 3 or 4 slow breaths over a 10-second interval. But it's certainly nowhere near as difficult as doing spirometry. So we can get younger kids and older people who have who are frail for multiple reasons. So it's definitely easier. And we're still refining. So part of this grant is really, is that the best way to do this, or can we improve on the testing? Results to come, hopefully. Thank you.
Thank you for a great talk. You just touched on one of my questions regarding whole blood.
Yeah.
And with like the methylation scores, the transcriptome scores, do you get a sense that you are, if you added those levels from whole blood, you get any additional information? What are you capturing from one that's not in the other? Is there a good deal of overlap between the two, both with the adipose and the nasal?
Yeah. So thank you. That almost looks like a planted question. Thank you. No. So for instance, for the top mass cohort that I mentioned has been recruited at Pittsburgh and is finishing follow-up, we collected nasal and blood. And the proposal was that we're going to look at nasal DNA methylation and gene expression. And I argued a lot about this, but I wanted to do whole blood RNA-seq and gene and methylation instead of white blood cells, because I wanted to be able to get a little bit closer to what I would expect in clinic. And so that proposal is going to look at those 4 omics from 2 different tissues, and we're going to see, is one better than the other? If so, does adding the second one add anything extra? That's going to be complex analyses, and so that may take us another year or so before we get to that. But I do think that you're going to learn from both. Right? What you can see in the respiratory epithelium is probably some immune signaling that's local that may trigger other things. What you're going to see in blood is more systemic inflammatory patterns. That's what I also hope to do with adipose tissue. So the adipose tissue I've been collecting, but I've also been collecting blood and PBMCs and white blood cells and aliquoting them. And hopefully one day I'll get the grant to get those done. I wish I had been able to do nasal in those patients, but like I said, when I collect that, it tends to be usually when surgery is involved, and inhaled anesthetics and all that probably change profiles, and so we haven't. I think the next iteration of this is going to be the adipose tissue, but then a subsequent visit where we get respiratory cells to try to integrate using respiratory cells as an outcome from what I saw earlier in adipose tissue. So I think there's going to be a lot of multi-omics coming up. Again, makes it exciting, but also very expensive and time consuming. Thank you.
About sickle cell and how it affects inflammation, which is sickle cell related chronic inflammation.
Yeah.
Have you thought about looking at that population?
Yes, I have thought about it, absolutely. I think it's a completely understudied and poorly understood phenomenon, right? Is it really they're more likely to have asthma? Is it something related to their sickle cell that leads to inflammatory changes that lead to a different type of asthma? And what comes first in terms of what you see in the like airways of kids with sickle cell? I haven't had a chance to expand into that, but I think it would be really interesting. You could also argue, though, right, in particular, that for those patients, it may be even more crucially important to also get some lower airways, which leads to some difficulties. But I think there are better ways we can get those nowadays. And I think collaborative research also can lead to that. But yeah, I think it would be absolutely really interesting to look at sickle cell. I haven't had a chance.
Yeah, because they can have obstructive and restrictive disease. So.
Yeah, and again, right, so some patients have a relatively low spirometry and they're doing perfectly fine. and some patients are in the hospital more frequently, and it's a different phenotype. And we also don't have a good way to treat them, right? We like to think that inhaled corticosteroids may help, but we don't really know. And I think there's a lot of opportunity to do better for them, by them. Thank you.